Good morning. If you haven't yet found a seat, if you could find one, that would be wonderful. I want to welcome you to the Culture and Mental Health session. As you can see, the title up front, though, is Mental Health, Culture, and Spirituality. My name is Renee Nicholas, and I work with InterVarsity Christian Fellowship as an area director here in Chicago. I also want to welcome the distance audience that we have that is with us through the live streaming today. And that is thanks to the generous support of the Good Shepherd Initiative of the Covenant Chaplains Association and the Covenant Ministries of Benevolence. If you want to text or email friends or family that want to watch the live streaming, you can see that right behind me here on the board. I want to make a brief announcement and let you know that the restrooms on this level are past the elevators on the right-hand side. So today we're excited to welcome our speaker, Pablo Anabalón. He's a licensed clinical psychologist working at Pacific Clinics in Southern California, and he's been there for over 15 years. He is a divisional director overseeing a number of clinics and involved with the integration initiatives within the agency, and also a part of the committee providing for training for cultural responsiveness. Dr. Anabalón is also the pastor of Iglesia del Pacto Evangelico in Eagle Rock, California. He has served on many boards and committees for the Evangelical Covenant Church, including the Covenant Board of Benevolence and the Pacific Southwest Conference, where he serves on the Hispanic Task Force and as a ministry associate. So please join me in welcoming Dr. Anabalón.
Thank you so much for the introduction. It's great to be here today, and it's great to be together discussing this wonderful topic. I got to meet Renee this morning, and understand she just got married last month, and I don't know if I'm allowed to say that, but congratulations publicly on that. And I'm among friends this morning, and I'm very blessed, honored to be sharing this morning on the topic of which I think we have many experts on the room. So hopefully I do part of the presentation, but we're also able to open up for some dialogue and conversation. Look like also it's a test of different accents. We start with a Scottish one, now you have a Latino one. But at the end of the day, you will be all confused. I'm particularly thankful to have David here for Board of Benevolence, and Hal Spooner, you know how glad I am to see you today and to see you well. So thanks for being here. Two things that I shouldn't have agreed. I agreed to this title in 50 minutes to discuss, and I don't know how we're going to do that. So will be probably an introduction of what we do. And I agree without knowing to the broadcasting or live scanning. So say hello to the camera. I don't know who is watching us, whatever they are. Let's pray. Dear God, we thank you so much for the opportunity you give us to be together, to discuss your kingdom. What a wonderful first presentation we had this morning that reminded us of the community you are calling us to be. Help us to respond to that call in a way that pleases you and bless our brothers and sisters. In Jesus' name, amen. I'm going to cover some different areas. I want to mention a couple of things about some diversity, both in the country and here. Then I want to discuss some issues on mental health and diversity, some implications for disparity, and then spirituality, to end up with some issues on the Latino population, which I serve more directly, to then open up to conversation and discussion that we may have. When we talk about diversity, when we talk about multicultural society, I don't think I speak anything new to that. One of the last numbers in terms of census describe this very diverse representation in the country of the different ethnic groups, with those numbers described there. Hispanic Latino becoming the largest minority within the country. I reviewed some numbers for Chicago and Illinois, and I was reminded also of this type of diversity we confront in this area with significant descriptions on some of those populations, both in the Chicago area and in the state of Illinois. There's estimated 460 languages that are currently spoken in homes in the United States. The National Center for Education Statistics estimate that between 1979 and 2008, the percentage of children who spoke a second language at home increased from 9% to 29% in that period of time. Of those individuals speaking language other than English at home, 62 speak Spanish, 19% spoke Indo-American language, 15% Asian or Pacific Island language, and then remaining 4% speak another language. So when we talk about this diversity, we talk about different backgrounds, we talk about different languages of the different communities we are called to serve as the body of Christ. Cultural influence many aspects of mental illness, including how patients from a given culture express and manifest their symptoms, their style of coping, their family, their community and supports, and their willingness to seek treatment. And I don't say anything new in this regard, that the way we see the illness or the presentation, we were reminded this morning, the way we name it will vary depending on the culture. So we are reminded in the morning of the fact that sometimes the person becomes that name, and usually the wrong name, and that's extremely extra challenging when we're talking about different cultures that understand the presentation, symptoms, illness in a way that is syntonic with the cultural ideology. Likewise, the culture of the clinician and the service system influence diagnosis, treatment, and service delivery. Cultural and social influence are not the only determinants of mental illness and patterns of service utilization for racial and ethnic minorities, but they do play important role. So we have intersection of probably three systems. We have here the people who are serving, the people who are providing the support and the service needed, the culture of the clinician. Yes. That one? Yeah. So the numbers don't match because the census divide between race and ethnicity. So when they're talking about white, they talk in terms of race, but then they break out, and that number could include also Hispanics and other ethnicities that are identified as white in that population. So that's the last census, the 2010 census description. Now, when we talk about the Hispanic population, that number usually does not include the undocumented population, which of course doesn't get through a census. So it may be that number is a little bit higher if you include 10 to 12 million undocumented, the estimated undocumented population in the country by the Pew Charitable Foundation projection in that number. So we said there's intersection of those three systems: the culture of the person or family or clients that we are helping, the culture of the provider, and the culture of the system. The system, the structure, the way we deliver the service has some ideology, has some principles based on that. So when we talk about culture, we talk about the combination of those three, of the individuals being served, the family being served, of the clinician, of the provider, of the pastor, of the counselor, and the culture of the system. So hopefully we're able to discuss those three this morning as they come together to provide service in a more effective manner. So in this regard, we say that our own awareness of our culture will play an important role, an important part on the way we provide services. The knowledge of the client's background and their skills with different cultural groups may be essential to improving access, utilization, and quality of mental health services for minority populations. So we say understanding that we have of our own culture, and then understanding of the other culture and the type of skills we develop in that process. I do think that for those of us who are in the helping profession, we have a God-given curiosity, respect, and appreciation for other people's culture. That would be my assumption, that if you are a pastor, if you are a minister, if you are a therapist, if you are a counselor, you are wired in a way that you have an appreciation for other people's culture, for other people's perspectives, and enjoy that. That will be my assumption. That will be my experience, interacting with people in the ministry, interacting with people in the field of mental health. So we start on a good point, but I also aware of the influence of the original sin on each one of us, and the tendency each one of us will have toward prejudice, toward stereotyping, toward misgiving in terms of understanding other cultures. So in the same way that we can see the beauty of God's image in other cultures and in our own, we have the risk of being blind to some of those factors that will keep us to serve the other in a more efficient way. So the more we know, the more we explore even our dark side, the more we'll grow in terms of becoming more efficient for this population. So we say the cultural has influence in the way we attribute the disease, stigma, response to treatment, family roles in relationship to illness, and role of spirituality. We were talking earlier with Pia, who is here somewhere. And oh, there it is. Thanks. We're reflecting on the presentation this morning, talking about stigma. And when we talk about Latino population, the issue of mental illness has even a bigger stigma. And I was doing a presentation on Tuesday with a group of pastors at Fuller, and discussing about the demonic and demon possession. And it came up on the reflection with that group of pastors that for the community of believers in our Latino experience, it is better to be demon possessed than to be mentally ill. And we're trying to figure out how will that make sense? That if you bring a different interpretation, a different alternative, it was almost a resistance to think, I think it's demon possessed. I think there's influence of the demonic. And I kept thinking on that. Why would that be? I think it may be because it could have then a solution, and that may be part of that. But I think it is related to the issue of a stigma within our community that are better be demon possessed than be confronted with an issue of a mental illness. Somehow acknowledging the presence of the disorder minimizes God's power in a way that doesn't say there's a demon possessed here. That doesn't minimize God's power, but saying has mental illness reduce the power of God in the community. So the way we understand illness, the way we understand wellness, the way we understand our spirituality, impact on those will be determined by our cultural background, by our understanding, by the way we embrace that factor in terms of our raising and the way we interact. There are two concepts that the DSM used to describe some more specifically the way we understand some particular presentations within a culture of an illness. So we have the idiom of distress and cultural bound syndromes, and those are two ways in which we acknowledge something that may be different to what we understand within a Western psychiatric model, some other way of presentations, some other ways of illness. The idioms of distress are ways in which different cultures express, experience, and cope with feelings of distress. One example, for instance, is somatization, the expression of distress through physical symptoms, stomach disturbance, excessive gas, palpitation, chest pain are common forms of somatization in Puerto Rican, Mexican American, and white. So what the Manual of Diagnostic Disorders says that there's some weight of manifestation of some illness that doesn't fit in the way we structure, doesn't fit in the way we see the different illness, as we were reminded this morning in terms of naming them. So how these different presentations in terms of culturally bound syndromes of idioms of distress challenge us to be cognizant of the way we recognize and acknowledge those type of presentations. I'm not going to spend too much time on this. I think the challenge for many of us who are serving within our communities is a double or triple one. We have the challenge of becoming more efficient on training ourselves, on being responsive, on being cultural responsive, on getting to know other cultures, on getting exposed, on embracing different ways to live the community, but also the issue of the disparities. Our system underserved our minority population in a significant way. The mental health system underserved our different ethnic groups in a way that is significant. If you see any numbers about public service, the groups that are underrepresented in terms of access to service is usually minorities. The sad exception is when we talk about schizophrenia among African American population. That's the number which is a higher representation than the general population. And it's a sobering reminder of our broken system in terms of diagnosis, because we know this is a number that is consistent among different cultures, and within the country is a group that is higher diagnosed than other groups in the country. But in general, the population of ethnic minorities tend to be underserved. So I think the challenge for us is not only to become very equipped to be cultural responsive in our one-to-one interaction with family in our ministry, but also to become advocates to address some of the barriers some of our ethnic groups have regarding accessing the services for different reasons in terms of availability, appropriateness, affordability, and also advocacy. The Affordable Care Act includes access to all the people that live in the United States except one group, and that's the undocumented population. So there is a dream, there's an aspiration to provide affordable care, health access to all those living in the country except those living in the shadow of the country. So I think the call for each one of us is how not only understand the one-on-one, at the micro level, the interaction we have in our direct services, but also the issue of the disparities that the system presents for many reasons, for many factors. The attrition level, for instance, within the minority groups is higher than other groups. The person, family, individual coming to a second session is lower within the ethnic groups. And in part, we think that's a problem for engagement. How do we engage the population where we're providing service? We are failing to the point that the people that not continue coming in a significant ratio or significant way. Some of the key barriers for mental health treatment are economics, the cost, the lack of awareness about mental health issues, and the stigma associated with mental illness. And I tell you a little bit more about my culture that I'm more familiarized. In my country of origin, many of our countries, you go to a mental health only if you are crazy. And then if you say you are seeing a psychologist or some provider, then it is because you are loco de la cabeza. You are that bad that you are reaching that point. So the understanding of accessing services in that context, it's driven by this extreme idea that this extreme group, the extreme population, will need access to those services. Some additional issues for access are educational challenges, the pervasive poverty, language barriers, lack of cultural appropriate services, lack of appropriate intervention strategies, mental health professional shortage, coverage in the United States. I was very blessed this morning with the presentation, and one description that John did was in terms of the intake process we do when we assess what's going on. And sometimes it's so blindsided that we met with a person, and I supervise a group of clinics, and I always am amazed with this process. We met with a person for 1, 2, 3 hours of their time. We serve underprivileged community in the area, underserved population. We met 1, 2, 3 hours, and after all that time we're asking 200, 300 questions. We ask people to sign documents, and some of our providers at the end do not offer anything back. We're so accustomed that we are the experts and they want to do what we're going to tell them, that some of our providers, after being with a person for 1, 2, 3 hours, they offer their story, they open up. We ended up telling them when is the next appointment, and we didn't provide anything back to them. We didn't give any feedback. In the worst case scenario, best case scenario, we provide some feedback, we summarize, we provide some conclusion of what we are doing. From that first encounter with some of our ethnic group, with some of the ethnic minorities, we're inviting someone to come to experience that may be alien to their culture, maybe alien to their experience. We're inviting someone to come that is coming with a hope that this is going to be solved in that first encounter. We are meeting with someone who may have some different perceptions of what is going on in that transaction. So how are we sensitive from the get-go in that process? Some of our cultures are gift givers, and what gift do we give back after engaging the person from that first encounter? How do we address some of the questions, some of the concerns, some of the misunderstandings of the transaction that is taking place as part of the way we equip ourselves in these areas? Some of the other barriers are attitude about mental illness and mental health can affect the use of services. For example, among some Latino, depression may be mistaken for nervousness, tiredness, or physical ailment, and may be viewed as something temporary. With the population we work in the clinic, we work with a severely mentally ill population, diagnosed with schizophrenia, depression, bipolar disorder. Probably some of the most heartbreaking experience for me in the clinical experience is navigating with a family whose son or daughter has just been diagnosed with schizophrenia. 16, 17, 18-year-old boy or girl who just presenting some of the symptoms, and then helping them to make sense of what's going on. I've been with families who come, walk in, and say, I think there's something wrong with what my son ate. I think something happened, something did a spell on him. And so different interpretations that are coming, walking into the process, walking into the system, and helping them walking through that. I could be subtly or openly dismissive of some of those interpretations, or embrace those interpretations as we walk along to the path of recovery and healing for that person. But I'm always amazed with what seems to be a pre-understanding, a preliminary understanding of what's going on and what's going to help the person to get better in that context. What a disheartening experience, and I think many of you have gone through that, of crashed dreams. For some of our people we serve, I work with a family whose mother said, very prominent mother, was a major in the area, said, she has said this publicly, so I repeat it for that reason. I had dreams for my son to go to college and to continue education. And now I wish that today he can take a shower. And that's part of readjusting some of the dreams and hopes I have for my son. So how we address that from the beginning of the interaction. Several studies have found that bilingual patients are evaluated differently when interviewed in English as opposed to Spanish, and Spanish are more frequently underrated. I find that very interesting because I think it's a sobering reminder that our system is not as absolute as we think it may be. So if you're coming with two different conclusions in terms of the way you are diagnosed based on the language you are assessing, something's going on either with the system or the way we experience the illness, we experience the symptoms in our language and the way we present. I think we are called to be culturally responsive in these areas of engagement, assessment, treatment, and follow-up. I think we are called to respond in an efficient manner, equip ourselves, and be better prepared in each one of these areas, starting with engagement, the diagnosis, treatment, and follow-up. Some cultural factors to consider in engagement and assessment and treatment. Language, the ability to communicate effectively, but informally in English, Spanish, knowledge and full acceptance of idiomatic expressions and level of language comprehension. I came to the United States when I was 27 and I didn't speak English. And some people say I still don't, but I do some. I do some. And I studied psychology, undergrad in Chile, Universidad de Chile, and I naively came to look for a job as a psychologist without knowing exactly what's going on. So I went to Lenterman Hospital in Pomona, California, developmental hospital. So I did find a job cleaning the halls and the bathroom where I was for a year. I was learning English then. And what a frustration to be in the midst of what I thought were colleagues and figure out what's going on at a developmental place without being able to engage intelligently because I didn't know the language. And I remember once sweeping the floor and trying to engage in a clinical conversation with a provider, which looked extraordinary to me, and it didn't prosper too much because of my broken English then. And part of my sense was I'm not as dumb as I sound. I'm a little bit more intelligent than what I sound. And many of our population that speak English as a second language are not as dumb as they sound. They have a lot to offer, but we have the barrier of the language in that process. We have the barrier of communicating effectively. You all know the challenges these are presented for the educational system. In California, we had labeled many bilingual kids with learning disabilities, with intellectual discapacities. We have labeled African American population in California to the point that testing for intellectual areas was forbidden for minorities for a long period of time in California because of the misuse of some of our instruments that almost look like a way to disempower population more than serve the population we want to serve. So how do we overcome, how we address some issues brought up by the language and the knowledge of expressions and level of communication? Even within groups, you'll know within Latino population, we have different ways to communicate, with different ways to express language. So there's some words that in my Chilean background are offensive that in other Latino contexts are not offensive. There are some words in the Mexican context that are offensive that in my context are not offensive. So even the nuances of the language that we address in terms of providing services. In terms of ethnicity and conditional acceptance of ethnic difference, class, status, country of origin, regional difference, mestizo syndrome, and color of skin. I was doing a presentation at a university in California 2 months ago, and I was talking about Latino experience, and there was a person that asked me, how is your experience in Chile as a light-skinned person. And I've never thought too much about that. I was a little bit surprised with the question, but then continue reflecting how even within groups we make those differences and discriminate based on some of those factors. So how we continue to embrace different cultures, how do we continue to embrace different ethnicities. And again, I think we all have a gift on that. God created us in a way that we're open to that, and we have a gift to embrace that. How do we get to know the myths, the values, the beliefs, and the religion of the people we serve, and the cultural poverty, lack of resources, lower education, illiteracy, and some issues of alcohol and drugs. If you study every minority group in terms of education, you'll see different ways that the curve develop in terms of elementary, secondary, higher education. They have different ways. And if you study within the Latino group, different groups, country of origin, will have different outcomes also in terms of the way you figure out the education the different population have in this country. When we talk about values, we talk about respect for the values in the family system, the roles in the family, and the expectation within the family members. And I keep referring to Latino culture because that's my background and my experience. Octavio Paz, a Mexican writer, described our culture as a mother-centered patriarchy. And that by itself is a complex idea. And if you don't figure out that, then you'll have difficulties engaging Latino families. If you don't consider that is a mother-centered patriarchy, then you can miss either one side of the equation on the population you are serving in the church or in the community of mental health. Some of the beliefs of the health belief, the mystical belief, the faith healers, medicinal plants, trust factors, systematized medicine, and mental health public system. I do struggle to some degree when we talk about, is that my echo? Yeah. I do hear voices, and we'll hear it, right? So, okay, thank you. I do struggle to some degree when we explore within Latino culture, for instance, the role of curanderos and alternative medicine. And I think the idea that all our cultures have something of God, and all cultures need to be redeemed and need to be transformed through Christ. So I think that the toughest role discerning that is how do you unconditionally embrace the people, value, culture, knowing that some of those values need to be redeemed, need to be transformed. Just to give an example of this, the role of woman in some of the cultures. So how do you embrace a culture in which you cannot embrace the way they see the role of the woman in that culture? And that is a tension on saying, I embrace, I unconditionally accept, but I also think this culture needs to be transformed, and I may be an agent of transformation for that culture. So in the same degree, how do you embrace things that are contrary to your beliefs? How do you embrace things that are contrary to your faith in a way that communicate respect, in a way that communicate that you are interested in helping the other person where they are? So I hope you're doing a good job on that. I'm still struggling with some of those issues, serving within the community for people that have a different perspective on some of the things I do value that may be valued in different ways. So part of my homework is to get to know those values and to accept them even if they're contrary to my values, and then to become agent of transformation also in that context. Within some of our groups, we have the issue of the role that religion plays, and as you know, Catholicism is the faith more prevalent within the Latino countries. And one issue that is important for us in the U.S. to keep in mind is that Catholicism in Latin America is a different experience than Catholicism in the U.S. and also in other parts of the world. The way that it has mixed with some of the other beliefs in Latin America, the way in which there's some syncretism, present a belief that it's sometimes foreign to the Bible, foreign to the experience that is expressed on that area. So some of this Catholicism come with a broader context in terms of the influence that have come up in that context. Some of our evangelical population in the U.S. are very anti-Catholic, and for different reasons. I think in terms because of some of the abuse they experienced growing up in Latin countries, for being cheated for many reasons. I can say many reasons that I may or may not share. So for some of our evangelicals who are serving Catholic people within the church or within counseling, they have some dissonance in terms of engaging, and they have some conflict in terms of engaging and serving the population. I serve in a Spanish-speaking church, loving church. I love it. I've been there for almost 20 years, great community, and I preach there. And one of my favorite authors is a Catholic author. So when I quote the author, I make sure not to mention there's a Catholic author, because then I'll get in trouble because of that. And this is why I regret that it's in the camera, so hopefully no one in the church is looking at this. We mentioned the issues of legal status, legal residence on the country, and the issue of immigration. If I can preach it to the choir and make a parenthesis here, some of our conversations about the undocumented population in the U.S. are so dehumanizing. You watch the news and you think on our kids who are kids, sons and daughters of some of our parents, and you think the way the language is used. I pray and hope that we bring dignity to the topic and to the conversation, even when we have difference of opinion, even when we approach it in a different way, that we use language that acknowledge that we're all human beings, that we were created in the image of God, and that we are in a place, in a country of immigrants, in a nation of immigrants that have been built on the contribution of many, many coming to this country. So I know I'm preaching to the choir, but that's part of my prayer, and I know the covenant has strongly support the embracing of serving our communities and addressing this issue in a way that embrace all of us who live in this country. Sorry, that's my preaching point. Some levels of acculturation. There are different models in which we understand acculturation, which is the way that the person become assimilated to the culture, assimilated to the area in which they live. And there are some classic models, old models, one of which are Barry from Canada, who says that there are two elements when we consider acculturation. The way you embrace the majority, the culture of the majority, and the ways you interact with your culture of origin. So the way he does is 4 quadrants, in which he said there's some people that in this process, continue of acculturation, totally embrace their culture, which they're being host, and refuse their culture of origin. So especially in the first wave, some of our adolescents, Sue and Sue in UCLA have described this. Some of our adolescents, the ethnic identity development start at that point, in which they fully embrace the dominant culture and they reject the culture of origin. So that's one possible scenario. Then another possible scenario is also in that ethnic identity development, there's some switch with some of our adolescents that now totally embrace the culture of origin and reject the dominant culture. So when you think on the developmental aspect, this would be a young kid who at age 8 will only eat McDonald's. And then at age 14 would only eat tamales and pupusas, because that will be part of the reflection of the process on the culture that is going through. So someone rejecting the dominant culture, embracing the culture of origin, and then someone who rejects the dominant culture that never assimilated, that was never able to live, to adapt, but also reject the culture of origin. So that's a tough place to be. And we see with some of our immigrants that are not happy here in the US and then go back to a country of origin and they're not happy there. They found everything wrong here and then they go back and they found everything wrong there. And it's a very tough place to be mentally and emotionally in terms of that double rejection. Then this author proposed the idea of a person that's fully integrated both in terms of the culture of origin and the dominant culture or the host culture, which is coming or embracing. A few things about spirituality. Obviously, spirituality can be a powerful tool to inspire hope, create motivation, and promote healing. Many persons from diverse multicultural communities utilize spiritual and faith-based organizations as a source of social support and hope for their healing process. The first place the person with an emotional problem goes to is the church. This has been documented, has been proven. They studied in Texas that the first place the person goes with an emotional and mental problem is the church. It's not the primary care, it's not the psychiatrist, it's not the psychologist, it's go to the church. So for the church people that are here, we better be prepared, because you will be the first one to be asked about the depression, about the bipolar problem, about the anxiety, about the PTSD. So we better be equipped. And why is that? Because we are trusted. We are trusted, and someone will not open up with anyone. We are trusted as a community that belong to. Many of you in the ministry are not only trusted with this, but with many other issues. We have a colleague, Pastor Samuel Galdames in Turlock, and we were in a meeting, 11 p.m., and he gets a call, and the person on the other phone is a church member, said, "Pastor, my bathroom is not working. What should I do?" So we are covering many areas, but in terms of mental health, we are the first point. We are the first point of accessing service, and we either provide the service or we become the broker, because there will be the first place where people will come when they're confronting some of these issues. Spirituality is an essential part on how people understand themselves and their world. It is not something separate. Some people experience altered state of being with a spiritual component that can support the journey of recovery. For some, this can be life-changing events. And I think that goes without saying on the way we address that and also discern between those. Often the spiritual component is ignored, labeled, or confused with delusions or other symptoms. I thought, I appreciate John's answer, I think was to your comment, on how we have been mutually suspicious between mental health and church. And this has not been an easy marriage. From Freud and other authors that label all our belief as delusions, to some people in the church that assume that the only way to provide assistance will be through the Bible. Now, efforts for integration have been saying that all truth are God's truth, and God revealed especially through the Bible, through Christ, but also through creation, and how we are able to integrate that and merge those two. And I appreciate the question that was asked this morning, and many of us in the church have moved toward the mental health area, in terms of opening, in terms of referring, in terms of creating. Not many of us on the mental health have moved toward spirituality. And the whole idea of Affordable Care Act is integration of services. And if we leave out spirituality, we have blocked out an important part of the recovery process for each one of the person we are serving. How we as a provider on the mental health embrace spirituality, embrace faith, bring in to collaborate those who are in the faith community in order to provide for the healing, for the growth, for the recovery of the person we are serving. Just a quick example of this, we're working with a very psychotic person having problems, voices that ask him to jump from the second floor because he could fly, and we're talking about medication, and he said, it's a Jehovah's Witness. I cannot take medication because I want to have a role on the church. If I take medication, I will not be accepted to be. He wanted to go to missions. I will not be accepted to do missions where I'm gonna go. So we wrestled a little bit and invited the person from the kingdom hall of that family to come in and to discuss that together. And that person said, that's not true on their belief. If he takes the medication, he will be better equipped to become the missionary he wants to be. And that was helpful to be able to collaborate with the belief that was different from mine, but to collaborate in a way that I couldn't have known. I could have assumed that what he's telling me was the truth. I could have assumed that this was it. But then bringing in others within the community of faith was helpful in that process. Some factors that promote recovery within the community of faith: a sense of community. Faith communities can offer a safe, comfortable, non-judgmental environment to mental health consumers. Personal outreach, the development of social network, and the community gifts of being present, of listening, and of friendship contribute to a validating environment. I grew up in a Pentecostal church in Chile, and we have no resources to mental health or health. So the only resource was the church. And we were the healing place for many of us in there. And one person that passed away 4 months ago, I will not mention his name, but I'll call him Andres, was with us until the age of 86. 86. And he passed away, and the whole community grieved his loss. He was a person that had been diagnosed with schizophrenia and served within the church, probably one of the most faithful servants in the church, in different areas, preparing the place, cleaning, welcoming the people, and in a wonderful, wonderful way. 86. You know what the average age, life expectancy for a person with schizophrenia in the United States is? 55. 25 years younger than the average population in the US. And of course, that's average and will differ from case to case. But this person's death at age 86 reminded me of the important place the community of faith will have in terms of giving meaning, giving a different name, as we were told this morning, and giving a place to those who are community at large will tend to segregate. An organization's spiritual hospitality expressed by both clergy and congregants can serve as a welcoming beacon. Persons with mental illness have opportunities for self-disclosure to tell their personal stories. We provide space, a safe space, to be able to provide some of those stories that we all have. We all have stories of recovery, brokenness, and wellness. People have opportunities to forge connections, spiritual or trust of acceptance. Consumers' participation in a contribution to the faith community are valued. A consumer can begin a relationship with a faith community simply by telling his or her story to a member of the clergy or lay leader and explaining how faith has been important for coping with mental illness personally or in the family. The whole recovery model has this idea that once you diagnose the person becomes the illness and become that label. What we are trying to do is to rediscover the person and rediscover the different areas. And the church has a key role in terms of rediscovering that person, reframing that illness, that presentation in the context of the whole person. The other area in which the community of faith has been helpful for recovery is in rituals of spiritual practice. Faith-based rituals and other spiritual practice can foster recovery among persons with mental illness. Rituals and other practice can include prayers, personal testimony, meditation. The form may differ, but spiritual practice are an important aspect and value of faith community connections with mental consumers. Faith communities can help people achieve solace and foster a greater sense of belonging. Now, also in terms of understanding mental illness, psychiatric disabilities, faith communities that understand mental illness and psychiatric disabilities are very able to meet the needs of mental health consumers. The following concepts are important for faith communities both to understand and to act on. I'm reflecting on the morning presentation and thinking of some of these labels. Some things that I'm challenged in terms of the blessed presentation we had was look like developmentally as a church at some point we had the need to acknowledge the reality of mental illness, and we have to use the name we have. So I think developmentally we had been in a place in which we have to use some of the languages. We have to recognize some of these realities which have had more demeaning names before, or have been ignored, or have been silent. So developmentally, we have named it, we have embraced some of the diagnosis. Now the next step is to rename it, is to embrace it in a recovery way that understands the person as a whole. So not to throw the water with the baby, to use some of this, but not also to bring the bad one on saying the person became the label, the person became the illness, but how to rename it and how to make sure as a church we have a role for the whole person. Each consumer has unique needs that require individual support rather than the cookie-cutter approach. Discrimination and stigma impede recovery. Faith communities that help overcome fears, stigma, and discrimination regarding mental illness are very able to serve persons with mental illness. Connectedness to family, faith, peers, faith community, or any other who listens and supports during a time of need is important to persons with mental illness. Empathy and listening help build relationships. Some of our communities can be helpful, and some of practice can be not helpful. Some of our practices and way we experience life together can be conducive to recovery, and some can hinder recovery. So within the area of mental health, how we acknowledge some of these elements that could hinder some of that recovery. Discrimination and stigma. The existence of discrimination and stigma with faith communities contributes to the burden of silence and secrecy consumers carry about the mental illness. What a beautiful representation we had in the morning, that a person in ministry feels the need to hide that, because if it is known, then we'll suffer from that stigma and discrimination. They may feel shame about their illness and fear about being judged negatively by members of faith community because of their illness. The perception by members of faith community that mental health consumers are somehow different may further heighten stigma and discrimination. I can say without problem that I'm taking medication for the heart, and I can preach about that, and I can share that. I don't know if I were taking antidepressant medication, I can say that freely in my community of faith. I can talk about different type of medication, different type of treatment, but this one is one that has that stigma, unfortunately, among our communities. I'm going to say a couple of things about Latino community and then open up for comments and questions. I know we have a lot of expertise on the room, so I want to make sure we take advantage of that as well. Like many other cultures, the culture of Latino is family-oriented. So when we think about ways to understand living, wants to understand the appreciation of life, we start on a concept of family-oriented, as many other cultures. I supervise some interns in the clinic where I work, and a couple of years ago had an intern who wanted to diagnose a 18-year-old adolescent Latino with a disorder of separation anxiety. And I tried to figure out why was that, and say, would you believe that her mother took her to college and walked with her to the classroom and make sure that she was in a safe place, and then went back? So I think there's something wrong with this person that's so attached to the mother. I didn't tell her that my mom walked me to college. No, she didn't. But then how we understand the family orientation, the value that each member has, the type of relationship we have, that are similar across cultures, but maybe a little bit closer. That we have a collective I rather than an individual I. That we live in a culture which promotes and values individuality, and comes from a culture that promotes and values collectivism. That is a we rather than an I. And how will that impact the way I serve? How that impact the way I treat those who are in need? So we call that familismo. Immediate and extended members at the backbone of the community. Latino culture value maintaining positive relationship with family members. These relationships are viewed to be preventive and protective factors in the lives of young women and men, thereby reducing the incidence of high-risk behaviors that may lead to suicide. In all stages of life, childhood, adolescent, adulthood, when you look for severely mentally ill population, living arrangement for adult population, a significant higher percentage of clients with schizophrenia live with their families than any other group. In a significant manner, those who are of Latino background live with their families compared to the other ethnic groups and to the other majority groups. Many of our minority groups struggle with end-of-life arrangement. Some of our ethnic groups think that putting your relative in a convalescent place is the worst thing you can do, that you are abandoning them. And then I'm going to keep it at my house, regardless how much it takes, regardless the challenges there are. I think for the same influence, for the same type of concepts and factors regarding familismo and also collectivism. The nature of family values are extended into communities. Research shows that Latinos have a preference to work in groups and generally live in close-knit communities. Mexican American students thrive when working with others in groups, especially when involved in goal-obtaining activities. Latinos place great value on interpersonal relationships. Young people, particularly those in middle school, may turn to families for advice. Respeto or respect in terms of the generational type of interaction. Emphasis placed in social worth, bestowing ultimate decision-making power of authority figures. The value of respect, positive communication, commitment, and appropriate expression of feelings are taught to program youth. Parents are provided with education and understanding to developmental needs of youth, establishing their autonomy, as well as supporting and strengthening their parental skills, thereby regaining appropriate control within their family system. When a Latino family comes to see the doctor, they come to see the specialist. They don't come to see a peer, they don't come to see someone they have an opinion. There's a very hierarchical relationship. There's a lot of this idea of respeto when it's communicated on that regard. Very seldom, I don't want to overgeneralize, but a person seeking service will use your first name to interact with someone providing services. And I think comes from this idea of respeto. A couple of things about Latino population and the faith. A very interesting study on the changing face of faith in the U.S., studying the Latino and their spirituality, produced by the Pew Charitable Foundation, Hispanic Center. Very serious research survey, very well done. And the same study shows you the methodology and the way they did this, and has a couple of things that I want to share with you that I thought were interesting in terms of spirituality for the Latino population. More than 2/3 of Hispanics identify themselves as Roman Catholics. The next largest category, 15%, is made of born-again evangelicals, Protestants. Nearly 1 in 10, 8% Latinos, do not identify with any religion. Difference in religious identification among Latino coincide with important difference in demographic characteristics. For example, Catholics are more heavily immigrant population than evangelicals. Given current demographic trends, Latinos are projected to become an ever-increasing segment of the Catholic Church in the U.S. And you can already see that on significant dioceses in Los Angeles, some cities in Texas, and some other areas, similar to what it was on previous decades, the influence of European immigrants, for instance, here in Chicago or in areas in Boston. For the great majority of Latinos, regardless of their religious tradition, God is an active force in every day. Most Latinos pray every day, most have a religious object in their home, and most attend a religious service at least once a month. The significant majority of Latinos who identify with a religion believe that miracles are performed today just as they were in ancient times. And I think that is very meaningful, very important, regardless of the denomination or the specific belief person has, that what an author described, the middle rung, that the Latino tend to live a little bit more on the middle rung, on recognizing and acknowledging the presence of the supernatural through the prayer, through thinking that God acts through miracle, through objects in the home. So we will be remiss not to consider that as we engage this group on the services we are providing. I'll end with this in terms of disparities of services. I mentioned at the beginning that many of our ethnic groups are underserved by the system. We are doing a great job as a church, but at times also we fall short in terms of the way of engaging and serving our minority populations in the United States. And that's where I think our call is not only to become proficient and competent individually, but also advocates to transform a system that need to be improved. Some strategies to increase that, reduce the disparity, reduce the gaps, to increase awareness of mental health and chronic disease connection, to conduct stigma awareness training with gatekeepers, to improve cultural competency, and to improve language accessibility, to advocate for policies that promote social justice, equity and equality, comprehensive, affordable health coverage for all, and focus on prevention and early intervention. We have all heard conversations in the country of the amount of money spent on the jail system, on the prison system versus education. And those numbers have to be disturbing. Those numbers has to be disturbing, and I think remind us of the need of investing in prevention, early intervention, rather than on intervention when the thing is full blown. I have a colleague who talks about early intervention like an angle, that if you do it close, if you do the intervention close to the center, you do a little bit, and they cause a big difference in the long run. If you want to intervene there, then you have to do a lot to have the same effect. So hopefully we're keen on the idea of early intervention and prevention. To increase accessibility and efficiency of services, clinicians and practitioners should adhere to the following guidelines and principles. Use of ecological perspective, and this is in an APA publication last year on the issues of addressing ethnic minorities. Integrate evidence-based practice with practice-based evidence, and there's a little play of words there, is where the model is coming. There's a big buzz on the community of mental health on evidence-based, outcome-driven. Some of those evidence models driven by more research, and some others based on the community, being born at the community level. Then provide culturally competent treatment, partner with community-based organizations, incorporate social justice principles, providing services. Of all forms of inequality, injustice in healthcare is the most shocking and inhumane. I love this quote not only because it accurately summarizes some of the conflicts and tension we have, but because it belongs to Martin Luther King. And a few years later, we may be in a similar place where he was describing at that time. Thank you for being here. Thanks for sharing, and I'll open up for comments or questions that you may have today. And only one at a time, because if not, get messy. One and one.
The mic as well. Is this?
You're doing that part, sorry.
Yes. Can you hear me through this? Okay.
Hi. Is it on? Can you hear? I teach, and I have a lot of Latino students, and many times they have a great many difficulties. My background is in psychiatric nursing. I teach health services management. What is the most effective opening sort of salvo or approach in order to motivate a person to obtain professional assistance?
So how do we help the people to seek professional assistance is the question. It may start with some education. When we tell someone in different cultures that they need assistance, they may understand what we're talking about. And I know you do this, but it may be educating on what does it mean seeking assistance and what role has this type of services within the community. And I think that's where the church can do a wonderful job in terms of destigmatizing the issue. And we are called also to educate. We're called also to inform. Where do you engage? How do you engage not only the person but the family, and consider to involve all of them in some type of treatment and some type of informant? I'll try to figure out what is the resistance, particularly in terms of their belief. What in the belief is that keeping them from seeking that assistance? For some people, is fear. And again, people that are undocumented, they may know that they need the service, they may want the service, but they think if they go and seek the service, they're going to be reported. So we need to find out. Is it fear because of that? Is it a conflict with some of the beliefs that they have? Is it the stigma that they are being seen because they're crazy and they don't think they're crazy? So I'll do education, assessment on where that resistance is coming from, and then engagement. How welcoming our environment, those who provide mental health services, how welcoming are from the most basic things. What type of painting we have, what type of decoration we have. Are those welcoming? Do they say, we embrace your culture, we embrace who you are? Or do they say, come to us, visit us? What does our ornament say about those? So I'll say those couple of things. Yeah. You must be a preacher.
A little bit.
Good.
I'm wondering if there's a difference between how it's experienced between those who have some of the diagnoses that you talked about with schizophrenia or depression, or those things that sort of occur organically by those diagnoses that are sort of thrust upon somebody through abuse or an experience where they have PTSD that we heard about this morning, where people are like, I can trace my anxiety to an experience by, you know what, I've always heard voices and they're getting louder and more complex, and there's a whole chorus going on in my head all the time. Specifically in the Latin culture, is there a difference between how those are perceived?
I'll say yes and no, based on my experience. I think there is so two things. There's not a clear sense even within the field on some of the etiological aspects of some of these things. So we think we have some understanding of some of them, some genetic studies that says high correlation with schizophrenia, the highest one with bipolar, and some of the things. So the difference with some of more environmental presentations. I'll say there's some difference, but sometimes they get all lumped together in terms of this is what's going on, this is what's needed. Some of the experience that I have in terms of theological thinking is how is sin present in there, and that then put all again together. How sin relate to mental illness. If someone is depressed, it's because it's not praying strong enough, and there may be some confession needed. I don't say everybody believes that way, but there may be some of the issues resonating in the back, and that will be for a whole different presentation, right? What is the relationship between sin and mental illness? And they're obviously connected, but sometimes we want to simplify it of saying because someone sinned is a mental illness. Someone sinned against us, as you were saying, in terms of abuse, and that result in a dysfunction, result in an impairment. So how the spiritual, theological factors may also be in part of that conversation versus environmental and genetic. So I'll say yes and no. They may be lumped together, but maybe some differentiation on that process. Any other comment or question? Yeah.
I don't need to. I've got 7 kids. I can project my voice.
So you can be in camera.
Okay, no, that's fine. Hi, I'm a chaplain at a federal women's prison in Edmonton, Alberta, Canada, and we see a lot of our inmates are affected by a mental illness, and a lot of times it ends up happening generationally, depending on what their condition is. One of the things I'm wondering is a lot of the stats that you've put up here today obviously are from the U.S. and pertain to the Latino population. Do you find that a lot of the factors tend to be trends globally when it comes to factors why people wouldn't be able to access services, be it financial reasons, not being documented, things like that?
Yeah. We live in such a time that migration is a reality in different part of the world, and many of these issues are universal, are across the issues. It tend to be population that in the periphery, in terms of financial system, in terms of accessing services. So if the services are easier to access, then it will be less of an issue. So it may change depending on how much accessibility, and I know some of the Canada system, but not as much as to say that. So it may have an impact on that regard, but then some of those are universal. The population country, you say Latino, with some of the groups, for instance, the Mexican population tend to have some level of education versus some other ones. So there may be some educational issues that could also be global. Would you think some of migratory movers from rural to urban areas, even within the country, tend to correspond also to correlate to educational level, and then it will be an issue of education in terms of accessing the services as well. So there seems to be some of those that are universal, some that are not. Barry, the author I quoted, classic on acculturation, is from Canada. He studied population in Canada. Interesting, some of the Latino population has some difficulties assimilating because of the traumatic way they leave their country of origin. So Canada opened the door for some of the immigration from Latin American countries around the civil arrest time. So it was so traumatic that by itself made it very difficult to assimilate in the dominant culture. So maybe some specifics on those areas as well. Yeah, and you want to wait for the mic? Thanks.
And if I can get the next person to tell me before, if anybody else has a question, raise your hand and I'll come back.
So I think you sort of tapped into it a little bit, like in the Latino cultures, trust is very important. So how do you address, maybe they don't seek help because trust is such an important part of the culture, and how do you let an outsider in to your inner circle of, even family, when sometimes we don't even want to discuss the fact that there is a problem with maybe someone having a mental illness?
Yeah. Thanks for the question. The question is, how do you build trust? And I think implicit in your question is the idea of the essential need to do that before any intervention. Because sometimes we think we can jump in right away to intervention. I mentioned evidence-based practice, and some of these models would say you have 10 sessions to treat this person. And some of our cultures, 10 sessions will take just to build the trust. So the first assumption there is it will take time, and I have to be in your agenda, will be time in which you are just doing that. Developing the trust, listening, developing the relationship. There may be, for instance, for church people, they may not trust the mental health provider, but they may trust the pastor or pastora. So that may be the person walking them to the system. So it's sort of vicarious trust. So I don't trust the system, I don't have reason to trust them, I don't know them, but I trust the pastor. So if the pastor comes with me and is embraced by the system, is received by the system. Sometimes we're so stuck on HIPAA issues, which I think are good. It's good to respect privacy, but sometimes we say no to talking to anyone because of HIPAA. Look like the H word. And we cannot talk to parents and to providers. And just like signing a release and that will do. But then we become very protective. How do we then, the mental health community, embrace those who can help us building that trust on being a bridge between a person that's in need of a service and a service that doesn't know the person, and it could be that bridge. So acknowledging the fact that we need to build it up, maybe treating this person will take longer, and then utilizing some of those bridges of people that vicariously could help us to develop some of that trust will be a couple of things I would say. Yeah.
With Latinos comprising an increasing percentage of the population, what trends or problems do you see in terms of having access to the mental health professions? You're the poster child, so.
Thanks. I don't know about the child part nor the poster one, but thank you. There are many issues. The 17% of the population they're projected to continue growth for many factors in terms of the immigration, but also the offsprings are higher between Latino population than other minority groups, so there's a natural growth in there as well. Some of the problems that we have when we talk about barriers for providing services with Latino is we don't have enough Latino providers. So two things that are needed: to train and equip, develop careers for people that need to come into the field. And again, I think church, schools have a key role on this. How do we help our young people to embrace a profession that may not pay that well, a profession that may have some hazardous side, but how do we encourage people that may have gifts in this area? So the shortage of equipped people, qualified people, that are not only Latinos, because if it's only Latinos, there's no way we're covered. But with everyone that continue to get equipped to provide responsive services to our population. So equip those who are not Latino, engage or recruit those who are Latino. I think in a macro level, there's a tension on how we continue to integrate our population. The gap that you have in acculturation, the bigger the gap, the bigger the problem is. There is a author in Miami, Cuban author, that studies families and says when the acculturation level within the family is big, when the member of the family is most acculturated compared to the least acculturated, that gap is big, then we have a higher vulnerability for drug and alcohol use and conduct problems and legal problems. And I think as a society we have the same risk. When the gap is big, then we have a higher vulnerability. I talk about underrepresentation in the service. We're overrepresented on the prison system. All our minorities are overrepresented there. And I think in part it's because of this gap. So what do we do to reduce the gap? To help our communities to embrace the dominant culture, to become acculturated, but also in both ways. So those are a couple of thoughts I have on that topic. Yeah.
I have a question about the use of interpretive services when trying to provide therapeutic support to a non-English speaker. Have you any ideas how to do that and do it well? I find that it is probably one of the most challenging things I do is speaking through an interpreter. There's not opportunity, I feel like, to really sit with questions or be with people, because it's like this game of tennis.
Yeah.
I don't know if at Pacific Clinics you use interpreters ever, if it's always the same language speaker therapists.
Yeah, we
Any
do.
tips you could give me?
Yeah, we do. And a couple of thoughts on that. We have trainings for this because it's so difficult. Sometimes people think it's a given. Someone speaks the language and then we use it. So how do we train people? The trainings that are online trainings for people doing interpretations. How do you prepare for that session? What type of conversations you have with the people? Instructions. Translating for clinical context is different than translating for other things. Sometimes we're a translator and we ask him how's he doing with the medication, blah, 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 and then the translator, he's fine. You know something is missing there. You know he may have said more than what he's translated. So what type of dialogue you have before in preparation with translators saying, I want you to translate everything, I don't want you to give your opinion, I don't want you to say anything different, because sometimes some interpreters feel, they're also caregivers, and feel so driven to help that they interject their own agenda and their own comments. Great intention, but not so helpful sometimes. So what type of discussion you have beforehand with them? Who is interpreting? Sometimes, because we don't have any other resources, we use family members, and that's probably the worst case scenario.
Yes.
Because how do you open your heart, how do you disclose, how do you say, and many of our adolescents have gone through that they become the experts that translate to their parents. And we put them in a tough place because they're addressing issues that they shouldn't be addressing. So what is the ideal in terms of the training, in terms of preparation after, in terms of debriefing after the session, saying this was helpful, this was not. If it's a person that's going to continue doing that, providing some feedback, you are training the person as well in that process. When it's done well, it's very helpful. And some people do speak English, but sometimes the emotional language is a native language. So even when the English is okay, when you're talking about the heart, the emotions, then it's a switch, because that's your emotional language. Yeah.
Yes. At the beginning, you mentioned that in the Latino population, sometimes it is easier to admit that you have a demon possession than to admit that you have a mental illness issue. I'm trying to figure it out if is it because it is easier to think for them that a prayer session will be more effective than a healthcare provider session?
Yeah, no, I think that's a good possibility, because I do have access to prayer. I do have access to this community, so that's a very good possibility of interpretation. Yeah, so you have no responsibility on that.
Hi, I wanted to know if you have any experience working with community health workers in California. I know it's becoming more and more of a trend because they usually speak the native language and the clients or patients can relate more to them. Do you have any experience working with?
Yeah, we have a lot, and it changed names in terms of community health workers. We're also pretty big on involving peers, people with lived experience, in order to help. We have in the making of a research study with USC on health navigation, how we help people with mental disorders to access health. There are different reasons that we cannot discuss now on why people that mental illness do not access health system in a way that they should do. And most of our severely mentally ill population, including the homeless, the way they access the health system is through the emergency room. And that's the only point, that wait until it's so critical that they go to the emergency room. So we're developing a program in which we're trying to help freeing up peers to help the people to access health in a different way than emergency system. The most effective people, we have tried case managers, clinicians, nurses, and some other people. All have done a great job. the most effective job is done by community workers, peer people that connect closer to the people. So not only have a role, but have a very significant role in that area. I think our time is up.
Do one more.
Okay.
It's the last
Great.
one then.
I've been thinking about your comment that Latino culture is a mother-centered patriarchy, and how decisions are made among family members when you have end-of-life situation and you're trying to make a decision about how to respect the patient's wishes. And when I'm a chaplain in a hospital, and I work in various settings, but when I'm making end-of-life decisions with the family, helping them, what kind of guidance would you give me in terms of both respecting the patriarchal nature and the mother-centered nature at the same time? How could I be sensitive about that that dynamic?
Right. And end-of-life issues with many of our ethnic groups are interesting and unique in some ways. Dying a good death in some of our cultures is a foreign concept and maybe even offensive, depending on the way you are presenting it. And even within Christian groups, again, because it may be underestimated God power or etc. How do you do that? My sense is what a European author long time ago described as a multi-directed partiality. How do you ally with both, the father and the mother, and recognize both roles that may be even that are in conflict or in tension? How do you communicate that in a way? So it takes a lot of art and skill in that way on how do you engage with both, but also understand the background in which some of these conversations come from, the context in which we address end of life, the context we address grieving, but then what respect you show to the father. This is the father figure. How do you communicate that? And how do you value the mother in that multi-directed partiality way? You have been a wonderful audience, Renee. You are
Okay, thank you. Thank you so much.